The case week 7 was a 28-year-old female with hand tingling. History of present illness was a female with bilateral hand and foot tingling that began 2 years ago, which went away and started again about 6 months prior. She had no precipitating factors to explain the tingling. The symptoms come and go without cause. She would have it some days present, but not always. It seemed to be getting better, and then there were times it was getting worse again. She denied any pain anywhere, just the tingling and intermittent numbness sensation. Initial concepts to consider are mechanical versus non-mechanical onset. If mechanical, we have to think micro versus macro trauma. If non-mechanical, is it an infection? Is it a tumor? Is it a blockage such as a thrombus or a DVT? Are we dealing with something metabolic, a systemic cause? This was the issue that most forgot in lab last week. Could it be an autoimmune condition? Could we have some functional issue like kidney stones, gallstones, MI, angina, etc.? Remember, these are general concepts that I'm talking about and not necessarily specific to this case. So remember, with unilateral sensory or motor changes, we have to think about 3 sources of compression or irritation: nerve root, plexus, or peripheral nerve. Given the fact that this is a bilateral presentation, this is really not applicable in this case. Once we've ruled out potential central nervous system and or metabolic issues, then we can go back to this sort of a concept. So we have to stop and identify the body systems involved. So what body systems? Could it be musculoskeletal, pulmonary, gastrointestinal, cardiovascular, etc.? So as noted in lecture, if bilateral symptoms are present, you must consider something metabolic, a systemic issue, or central nervous system involvement. Something metabolic could be diabetes mellitus, thyroid diseases, nutritional deficiencies, anemias, heavy metal poisoning. So when we start to look at metabolically based conditions, although this list is not all inclusive, we have to look at the digestive system, the endocrine system, the pulmonary system, the cardiovascular system, as well as the hematology. So in this case, we should have recognized that we could be dealing with a neurological issue, being that of central nervous system. We should have also thought of maybe something hematologic, such as an anemia. The patient is tingling in all 4 extremities. This could indicate that we have some sort of hypoxia in the extremity. We could also be dealing with a digestive issue, some sort of malnutrition, malabsorption issues. Remembering that we need B12 to mature, B12 and folate to mature red blood cells. If we are unable to mature the red blood cells, then the patient could end up with an anemia. We could be looking at some sort of vascular involvement in terms of an occlusive vascular issue. In this case, because she had no coldness or paleness in her hands, it was less likely we were dealing with an occlusive vascular issue. Could there be an endocrine issue? And could we be dealing with musculoskeletal? It's unlikely unless we think that the musculoskeletal system is putting pressure on the nervous system and or vascular system. In that case, usually you have some sort of pain associated with it. So, remembering, if the central nervous system is involved, we need to screen cranial nerves, balance and coordination, gait, memory or cognition, and bladder changes specifically, but bowel as well. So in our review of systems, or our focused review of systems, we need to be we found out that she had double vision. She had this blurry vision, especially when she was trying to surf our text. Occasional headaches with the vision changes. She denied any chewing, swallowing, taste, or hearing issues. We weren't really dealing with any other motor issues or other special sensory issues. She denied any memory loss. She did have occasional dizziness with some balance issues. Urinary hesitancy was noted without any pain. She did deny any weakness, which is then, again, ruling out some of our motor conditions. And coughing, straining, or sneezing did not increase the symptomatology, helping to rule out some sort of central cord involvement. Although she did have tiredness, which was unexplained. Once again, this question should be asked when we're thinking metabolically based conditions. Her family history: his mother was healthy, father did die of a heart attack at age 56. Social history was that she denied tobacco or recreational drug use. Did drink about 1 to 2 martinis a week, and she was an office assistant for her occupation. She was typing and answering the phones all day, in which the hand tingling seemed to bother her slightly, but not overly significant. Her effect on daily life: she was able to get dressed although had some difficulty buttoning her shirt when her hands were bothering her. She was able to sleep without issues, but she was unable to read when her eyes were bothering her. Our initial clinical impression that we worked through lab was that multiple sclerosis. We also spoke about the fact that it could be a B12 or folate deficiency leading to a megaloblastic anemia, as well as pernicious anemia. So when we talk about megaloblastic anemia, this is a vitamin B12 or folate deficiency. It's also known as macrocytic anemia. B12's primary sources are found in meat products. However, folate is found in meat, vegetables, and fruit. Folate deficiencies are harder to achieve. B12 deficiencies are especially seen in vegans. Now, B12 is the only water-soluble vitamin that is stored. Up to 3 milligrams is stored in the body and 1 milligram in the liver. The liver can hold about 3 to 5 years of storage before deficiency is noted. This is a concern for vegans and post-surgical gastrectomies, some of the gastric bypass surgery. If they are not supplementing B12 over a period of time, they will start to run out of their stores in the liver. The body can no longer make myelin, and they start to get degeneration in the spinal cord that is not reversible. So, causes of deficiency, we have strict vegetarians or vegans, also atropic gastritis or achlorohydria. Tend to see this in the elderly. They have more difficulty digesting food. We have a failure of intrinsic factor production. Pernicious anemia can be known for this in terms of the hypersensitivity and or autoimmune reaction. Also, some of the H2 antagonists, such as Zantac, Pepcid, Nexium, can inhibit the secretion of intrinsic factor. These are the acid-reducing proton pump inhibitors. We also have disorders of the terminal ileum. Some of the inflammatory bowel disease, lymphomas, tropical sprue can also cause deficiencies in B12 because we can't absorb in the bowel. So pernicious anemia. B12 is taken in by the diet. And B12 is then attaches to intrinsic factor, which is a carrier protein that is found in the stomach, released by the parietal cells of the stomach. This bound chemical then travels to the terminal ileum to be absorbed. If we have autoantibodies that attach to the intrinsic factor, making it unavailable for B12, B12 will not be absorbed. It will not move from the gastrointestinal system to the cardiovascular system, and it will never get into the cells of the body. So when we look at the physical exam in general, in a neurological exam, we need to inspect. Evaluation for station. Are they stable when standing? We want to see what their gait is, what their ambulation is, whether we're dealing with altered gait in terms of, is it a slappage gait? Is it a staggering gait? A slappage gait should lead us to dorsal columns. A staggering gait should lead us to a vestibular issue, possibly, but more likely, motor ataxia cerebellum. Is there any atrophy leading to motor neuron disease, lower motor neuron? If we have some fasciculations, that could be lower motor neuron findings as well. So we want to palpate for muscle tone. If we have spasticity in the muscles globally, we think upper motor neuron lesions. If there is flaccid muscle or decreased tone, we're going to be looking at a lower motor neuron. Global tonal changes can be seen with basal ganglia disorders, such as Parkinson's or Huntington's chorea. So range of motion we want to assess for quality and not only quantity. So with cogwheel or lead pipe rigidity, we consider a basal ganglia disorder, remembering that lead pipe rigidity does not have a tremor associated with it, where cogwheel rigidity does. The neurological exam would consist of mental status, cranial nerves, motor, reflexes, coordination gait, and the sensory exam. Mental status. We want to see if the patient is alert and orientated on all three planes. It is recorded in the file as AOX3. Do they know who they are, where they are, and when they are? Much of this information comes out of the case history. We want to look at orientation, level of alertness, memory, language. You can evaluate calculations. You can evaluate apraxia. Sequencing of tasks, abstraction. Please refer to the lab manual for further information on this. Want to evaluate cranial nerves. So we're going to look at the special sensory cranial nerves of sight, smell, taste, and hearing. The motor, looking for the cardinal fields of gaze or extraocular eye movements. evaluating cranial nerve 5, the motor for mastication, cranial nerve 7 for facial expression, whether or not we can vocalize with cranial nerves 9 and 10, with tongue movement, cranial nerve 12, shoulder elevation and neck rotation with cranial nerve 11. You also want to evaluate the autonomic reflexes, the pupillary reflexes, direct and indirect light reflex, accommodation. One of the conditions that is seen with multiple sclerosis is something known as internuclear ophthalmoplegia. It affects lateral conjugate gaze. What happens is the medial longitudinal fasciculus, which is a highly myelinated tract, becomes demyelinated with multiple sclerosis. This tract gives rise to the medial rectus. So the patient has the inability to medially deviate their eye past midline. So there's a video that I have posted on Blackboard that shows a gentleman who has internuclear ophthalmoplegia. He has difficulty moving his eyes side to side. Please watch that video to get a better understanding. The other thing we also see with MS is optic neuritis, where inflammation of the optic nerve is seen due to demyelinization. They get abrupt vision loss in one eye. Central vision is affected. Peripheral vision is still maintained. So when doing visual fields by confrontation, the patient usually has the ability to see peripherally but not centrally. They may have some pain associated because of the inflammation. It is usually self-limiting. 4 to 12 weeks it dissipates. And prescription lenses do not help the visual loss. On our motor exam, we want to look for fasciculations, atrophy, alterations in posture due to muscle tone. We want to look at muscle strength testing, and we want to assess passive range of motion for rigidity, as I noted earlier. Reflexes, we want to look at our deep tendon reflexes or our myotactic reflexes, looking to identify whether or not there is a +3 or greater deep tendon reflex. Sometimes this is difficult to identify in a patient, so it is best to use pathologic reflexes to determine whether or not the patient has an upper motor neuron lesion. We also want to look at our superficial and visceral reflexes. This helps reiterate the reflex arc. Take a look at this if you still have some difficulty with this. So plantar reflex. The bottom of the patient's foot is stroked lateral to medial along the calloused portion of the foot. The normal response is that the toes should curl. If the toes do not curl, it is because either sensory or motor is not working on the bottom of the foot, which is tibial nerve, also integrated at the spinal cord at levels S1 and S2. If the great toe dorsiflexes and the other toes splay out, that is Babinski sign is present. Babinski sign indicates an upper motor neuron lesion or pyramidal tract lesion, as those are synonymous terms. So let's watch this video that Dr. Blumenfeld is doing on plantar reflex.
Test the plantar response using a sharp object such as the back of a reflex hammer and drawing it straight from the heel along the sole of the foot in an arcing motion towards the toes. And observe the first movement at the proximal joint of the great toe. The normal response is flexion. Extension is the abnormal response, also called the Babinski sign.
We'll also look at the coordination and gait exam, evaluating cerebellum with finger to nose, heel to shin test, pronation supination test, padding test. We'll also look at gait for forced and tandem gait. The sensory exam would consist of evaluating the dorsal columns, palæsthesia, 2-point discrimination, Romberg's, spinal thalamic with pinprick, maybe sharp versus dull, anterior versus lateral spinal thalamic. Evaluating the somatosensory system with sterognosis, graphesthesia, barognosis, 2-point discrimination. Please note 2-point discrimination in many of the sources is both under dorsal columns as well as somatosensory. The theory behind that is that dorsal columns is discriminatory sense. The reason many books consider it a somatosensory test is because A, they have to be able to feel that which is spinal thalamic, and B, they then have to distinguish that which is dorsal columns. We'll accept either on the exam, and a written exam I would not have those as independent of choices to choose between dorsal columns or somatosensory. So the physical exam for this patient would consist of vitals. We would inspect for staggering gaits, slappage gaits, scissoring gaits, etc. We'd palpate for muscle tone. We would do range of motion to rule out basal ganglia involvement. Cranial nerve exam specifically would consist of direct, indirect accommodation reflexes, as those are usually signs seen with multiple sclerosis. We'd evaluate the cerebellum, padding test, pronation, supination, finger to nose, etc. Evaluating the dorsal columns with Romberg's, palästhesia, light touch, and then pathological reflexes in the lower extremity looking for Babinski's sign, in the upper extremity, Hoffman's, Tromner's. So what is the next step with this patient? Well, the first thing that needs to be done is blood work to make sure that they do not have a B12 deficiency. So CBC with differential, an anemia profile, and a B12 assay would be ordered. A referral for a neurologist for an evaluation would be an appropriate step, as well as an EMG or an NCV to determine whether or not there's motor loss and or nerve conduction loss due to demyelinization. An MRI would be done, and this is where the exam needs to identify, do we have cord-related involvement versus brain-related involvement? So one of the tests that is done for the identification of pernicious anemia is Schilling's test. Also, you can run autoantibodies against intrinsic factor in the parietal cells. So with Schilling's test, the patient is injected with non-radioactive B12, and then they are also given radioactive B12, and then urine samples are collected to see if B12 is getting into the urine through either the muscle or the digestive system. And that will help differentiate whether or not there is a B12 deficiency.